So the next table which we will discuss is pharmacodynamic properties of inhalational anesthetic agent, right? So let us discuss the effect of these agents on different organ systems, starting with central nervous system. Okay, so halothane, isoflurane, sevoflurane, desflurane. So the first organ system which I will discuss, central nervous system. Now before I tell you the effect of these agents on CNS, let me tell you few things related to the physiology of CNS, which would be related to our discussion. Okay, whenever our brain is very active, as it must be now when we are actively discussing something, whenever our brain is more active, the oxygen requirement of brain increases. And whenever oxygen requirement of brain increases, to meet the demand, the blood flow to the brain increases, cerebral blood flow increases. And whenever we are sleeping, right, or let's say when we are unconscious, the oxygen requirement of brain reduces and cerebral blood flow reduces. This is what we call is coupling of CNS. What do I mean by CNS coupling? So let us write here that central nervous system, CNS coupling. What do I mean by CNS coupling? I mean by this is that cerebral blood flow directly proportional to cerebral metabolic oxygen requirement. Cerebral blood flow is directly proportional to cerebral metabolic oxygen requirement. Okay, this is called CNS coupling. Any clinical condition which would decrease cerebral metabolic oxygen requirement, cerebral blood flow should, as a rule of coupling, decrease. And if CMRO2, that is cerebral metabolic oxygen requirement, increases, cerebral blood flow increases. This is a normal phenomena which we observe. Okay. Now let us say, guys, what does anesthetic agent do? Inhalational or IV? They do the same thing. They make the person unconscious. That's why we are giving them. And once the person becomes unconscious, then definitely what happens? The activity of brain reduces and the oxygen requirement of brain would reduce. So all anesthetic agent, irrespective it is inhalational or IV, do the same thing. Decrease CMRO2. So first point I am writing, they all are doing the same thing. Decrease CMRO2, cerebral metabolic oxygen requirement. Decrease CMRO2. Okay, decrease CMRO2. Okay, so they all are doing same thing, right? If I was discussing with you IV anesthetic agents also, I would have written the same thing. All anesthetic agents do the same thing. Now, according to the rule of coupling, which we just now discussed, what should be the next statement? Decrease cerebral blood flow. All anesthetic agents follow this rule, except inhalational. Inhalational anesthetic agents have a direct effect on the blood vessels of the brain. They dilate it. And we all know whenever the blood vessels would dilate, the blood flow in it would increase. So instead of decreasing cerebral blood flow, because of a direct effect on the blood vessels, inhalational anesthetic agent increases the cerebral blood flow. So cerebral blood flow increases. This is not normal what we discussed. Inhalational anesthetic agents are uncouplers of brain. Okay, cerebral blood flow increases. Cerebral blood flow increases. Cerebral blood flow increases. Instead of decreasing cerebral blood flow, they are increasing cerebral blood flow. Guys, if I was discussing with you IV agents, I would have followed the rule. Inhalational does not follow the rule. If cerebral blood flow increases, what is the effect on ICP? Intracranial pressure. ICP would also increase. So ICP increases. Cranium has fixed capacity. Any component increases, ICP would increase. So ICP increases. ICP increases. Got it? Okay. Guys, if I was discussing with you IV agent, I would have told decrease CMRO2, decrease cerebral blood flow, decrease intracranial pressure. Inhalational, decrease CMRO2, but increase cerebral blood flow, but increase ICP. So IV anesthetic agent decrease ICP, inhalational increase ICP, right? And in inhalational, if you notice in the table, in the chart, I have made 3 arrows in upward direction in halothane purposefully, trying to tell you halothane increases the cerebral blood flow maximum. Maximum a agent can increase. So halothane is increasing cerebral blood flow maximum. Okay, it's the worst uncoupler. If the ICP of the patient is 20, halothane can make it 60. 3 times increasing the ICP. Now let us consider a patient posted for some neurosurgery case. Patient has a space occupying lesion in the brain, a tumor in the brain. Already ICP is more. If I give inhalational, ICP would increase further. If I give IV, ICP would little bit decrease. Better for the patient. So this is the first benefit of TIVA over inhalational. TIVA, total intravenous anesthesia, we talked about, is better for neurosurgery as compared to inhalational because IV anesthetic agent decreases ICP, inhalational increases. So if they ask a question in exam, single best agent for anesthesia in neurosurgery, answer would be propofol, TIVA, total intravenous anesthesia. Among inhalational, halothane is contraindicated for neurosurgery. Halothane, contraindicated for neurosurgery. ISO, SIVO, DES. ISO, SIVO, DES. All 3 can be used for neurosurgery. They all increase ICP little, which can be tolerated. So all 3 can be used for neurosurgery, right? All 3 can be used. Guys, ISO is also good, SIVO is also good, DES is also good. Now earlier they used to mention ISO is maintenance agent of choice for neurosurgery because DES was not in the clinical use. Today also, at maximum centers, ISO is in use for neurosurgery among inhalational because DES is not available. But the centers which have DES available, DES is best, is agent of choice. So guys, if they ask among inhalational single best agent, with DES in option, answer would be DES. With DES not in option, answer would be isoflurane. You're getting my point? ISO is very good. Additional benefit of DES has made desflurane best. If they ask best agent for maintenance in among inhalational for neurosurgery, answer would be desflurane if it is in the option. Most common agent in inhalational agent for maintenance, answer would become isoflurane because DES is used at very less places, very few places. DES is still not so much available at every place, right? But best agent if they ask, without doubt desflurane, in spite of anything else written in the guidebooks. Got it? Additional benefit of DES has made DES a better agent. Okay? Now please tell me, further discussing the effect on central nervous system, please tell me what is EEG? What is EEG? So we are discussing halo, ISO, SIVO, DES, and we are continuing with central nervous system, CNS continued. Guys, what is EEG? Electroencephalogram. We all know if brain activity is more, EEG increases. If it is less, EEG decreases. All anesthetic agent and intravenous anesthetic agent decreases EEG activity because they all decrease the brain activity. So EEG decreases. All of them decreases EEG activity. They do the same thing. EEG decreases. Okay guys. If a drug decreases EEG activity, they become a good drug as anti-epileptic agent. Well, if you know the definition of refractory status epilepticus, the definition is status epilepticus, that is continuous epilepsy, not responding to routine anti-epileptic. What do we do in this situation? Give anesthetic agent, preferably IV, but can also be inhalational, can also be given, right? Only an anesthetic agent if it increases EEG activity, then only it should be avoided in patient with epilepsy. Otherwise, all anesthetic agent decreases EEG activity, brain activity, and are anti-epileptic. Okay, got my point? Okay, here I want to note for you what are the conditions which decreases and increases EEG activity. Okay, so see on the screen. Conditions decreasing EEG activity and increasing EEG activity. Okay, now decreasing EEG activity, hypoxia, hypercapnia, hypovolemia, hypothermia. We have earlier also discussed these conditions. They produce CNS obtundation. They all will decrease EEG activity. But when they are in their early stage, early hypoxia, early hypercapnia, early hypovolemia, early hypothermia, when they are in the early stage, there is a sympathetic stimulation, right? Because in early phase in hypoxia, we try to fight against hypoxia. There is a sympathetic stimulation, and then EEG activity at early phase would increase. But if per se hypoxia is written alone, it decreases EEG activity. So these three in their early stage increases EEG activity. Got it? These four in their early stage increases EEG activity. Got it? Now, all inhalational and intravenous, right, anesthetic agent decreases EEG activity because they all decrease the brain activity. Only two anesthetic agent, ketamine and nitrous oxide, both increases EEG activity, though anesthetic agent. Why? Because both of them are sympathomimetic. Both of them are sympathomimetic. Guys, nitrous oxide is sympathomimetic, not of much problem because it is not used as a sole anesthetic agent, used with a potent agent. So this effect is negated, but ketamine is a sole anesthetic agent. And if I give it in a patient with history of epilepsy, it can precipitate epilepsy. Got my point? So ketamine would be contraindicated in patient with history of epilepsy. We would again repeat this when I would discuss with you IV anesthetic agent, in which I will discuss ketamine with you. Got it? In details. Understood? For now, I want to tell you just what are the drugs and clinical condition decreasing EEG activity and increasing EEG activity, because few questions are asked related to it. Okay? Now tell me, what are the two agents which I told you not in clinical practice? One is methoxyflurane. Why methoxy is not in clinical practice? We have written because it is most nephrotoxic. Which is the other agent not in clinical practice? Yes, enflurane, right. Now, why is enflurane not in clinical practice? What do we know about enflurane? We know about enflurane, it's isomer of isoflurane, and isoflurane seems to be a good agent. Then what is the problem with enflurane? Remember guys, E for enflurane, E for enflurane, E for epilepsy, right? Enflurane precipitates epilepsy in every patient exposed to it. If not every, 90% patients exposed to it. So it was abandoned from clinical practice. Guys, now this question was asked in exam so many times. And this question was asked in exam that which drug precipitates epilepsy or seizure in 2013 All India Entrance Exam, and there was enflurane not an option. When this drug is not an option for epilepsy question, go for SIVO as the second agent which can precipitate seizure. SIVO, normally human cases yet not reported precipitating seizure, but animal studies have shown that it can precipitate seizure. Question has been asked, so you have to keep it in mind. Okay? So SIVO can precipitate seizure. SIVO can cause seizure. We have to keep it in mind. Sevoflurane can cause seizure. Got it? So this is the effect of inhalational agent on CNS. We discussed the effect of inhalational agent on CNS, compared it with the effect of IV anesthetic agent, and discussed for neurosurgery how to approach the question, and discussed for epilepsy how to approach the question, and discussed drug precipitating epilepsy how to approach the question, right? So we have solved a lot of questions. Now let us move to the next organ system, cardiovascular system. So next organ system is cardiovascular system. Okay, so we will discuss cardiovascular system. Halothane, isoflurane, sevoflurane, desflurane. Okay, cardiovascular system. Guys, very important. When do you say a drug is cardiovascular unstable? We say a drug is cardiovascular unstable when the drug has any effect on cardiovascular system, excitatory effect or inhibitory effect. If a drug increases blood pressure or decreases blood pressure, increases heart rate or decreases heart rate, increases cardiac output or decreases cardiac output, any effect, it is cardiovascular unstable. When do we say a drug is cardiovascular stable? When it has no effect on cardiovascular system. Got my point? Then again, before discussing this, I want to tell you, in neurosurgery, I told you single best agent, IV, propofol. Same I can't say for cardiovascular system, because the major problem of most of the anesthetic agent, inhalational or IV, is cardiovascular instability, right? And there is no single best agent for cardiovascular surgery. Among inhalational, this is good. Among IV, that would be good. So I can't compare the effect of inhalational and IV on cardiovascular system, right? Again, one more point before starting the discussion on cardiovascular system. A drug may be cardiostable but cardiovascular unstable. A drug may have no effect on heart, but by its effect on vascular system becomes cardiovascular unstable. Got my point? So keep in mind these 3 points, and let us start our discussion with the effect of inhalational agent on cardiovascular system. Among the 4 agents written on the screen, only halothane has a direct effect on heart. It is direct myocardial depressant. Okay, so let us discuss. We are discussing halothane, iso, sevo and des, and we are discussing cardiovascular system. And I told you, only halothane has a direct effect on heart. What does halothane do? Direct myocardial depressant. What does it depress? It depresses the activity of SA node, decreases the activity of SA node. What is SA node? Pacemaker of heart. So what would happen? Heart rate would decrease. Heart rate decreases, right? Whenever heart rate decreases, what is the effect on cardiac output? Cardiac output is equal to heart rate into stroke volume. Heart rate decreases, cardiac output decreases. Got it? So whenever cardiac output decreases, blood pressure decreases. So what is halothane doing? Bradycardia, hypotension. Got it? Okay. Iso, sevo, des. The next 3 agents. No effect on heart. They have no effect on heart. Right? They all are cardiostable. They are cardiostable. Here I want to tell you 2 types of question. Most cardiostable. Here I want to tell you a common question. Most cardiodepressant inhalational agent. Clearly halothane. Least cardiodepressant or most cardiostable inhalational agent. Desflurane, not an option. Sevoflurane, not an option. Isoflurane. Got my point? From recent to the older one, from latest to the older one. Got it? Des, most cardiostable, not an option. Sevo, not an option. Iso, most cardio unstable. Halothane. Rest 3 cardio stable. Now, iso, sevo, des are cardio stable, right? But not cardiovascular stable. Why? Because they have effect on vascular resistance. They decrease systemic vascular resistance. Systemic vascular resistance. Guys, what is systemic vascular resistance? Tone of your blood vessels. It is decreased. So all the blood vessels dilate. So blood pressure, diastolic blood pressure reduces and mean arterial pressure reduces. Mean arterial pressure reduces. And whenever arterial pressure reduces, there is a reflex sympathetic tachycardia. Heart rate increases. So this is the effect of iso-sevo-des on cardiovascular system. Hypotension, tachycardia. What about halothane, which we discussed earlier? Bradycardia, hypotension. So which is the only inhalational agent causing bradycardia? Halothane. You know guys, halothane came in clinical practice in 1951, right? Iso came in clinical practice in 71. 2 decades it was only halothane. And in those 2 decades, there was a common practice among anesthetists to pre-medicate their patients with IV atropine to counteract bradycardia causing side effect of halothane. This question has been framed like this in exam. Which side effect of halothane is counteracted by IV atropine? Answer is bradycardia. Got it? Okay. Now next effect on cardiovascular system. This was the first effect we discussed. Second effect is an indirect effect through catecholamine. Guys, whenever serum catecholamine level increases, what happens? Blood pressure would increase, heart rate would increase, and if it crosses certain serum level, arrhythmia and cardiac arrest can happen. Got my point? Inhalational anesthetic agent, that certain level increase decreases that certain level increase. What do I mean? Inhalational anesthetic agent sensitizes the heart to arrhythmogenic effect of catecholamine. Forget iso-CO-DES, only remember halothane. Halothane sensitizes the heart most. It makes the myocardium very sensitive to arrhythmogenic effect of catecholamine. So under halothane anesthesia, if any reason serum catecholamine level increases, arrhythmia can get precipitated. Got my point? Arrhythmia can get precipitated very fast. So halothane not only causes bradycardia, it also causes arrhythmia by a different mechanism. Got my point? So write it. That halothane, second point, sensitizes the heart maximum to arrhythmogenic effect of catecholamine. Arrhythmogenic effect of catecholamine. Okay? Rest of the agent, minimal. No need to remember. Only remember halothane in this pretext. Okay? Third effect on cardiovascular system. Guys, before coming on the third effect, I want to ask you, pheochromocytoma, which inhalation agent should be avoided? Halothane. Why? Little increase in catecholamine in the blood, arrhythmia can get precipitated. Right? Okay, third effect. A special effect produced by only one inhalational agent, isoflurane. Isoflurane produces a unique phenomena on heart, coronary steal phenomena. Coronary steal phenomena. What is this coronary steal phenomena produced by isoflurane? Coronary steal phenomena produced by isoflurane. Right? What is this coronary steal phenomena? Guys, this is heart, let's say, it has an ischemic area and blood flow to this area is less. If I give isoflurane to my patient, it selectively vasodilate all the normal blood vessel, not the ischemic blood vessel. What happened? Blood from, let's say, ischemic area would go into the normal area. Ischemia can get precipitated, right? Selective vasodilatation of non-ischemic areas blood vessel by isoflurane precipitates coronary steal phenomena. Ischemia can get precipitated. Direct question asked, which inhalation agent causes coronary steal phenomena? Isoflurane. Indirect question asked, patient with history of MI, history of angina, which agent should be used cautiously? Isoflurane. Isoflurane causes coronary steal phenomena. Got it? So these are the three things we have to discuss in cardiovascular system. Now for cardiovascular surgeries or patient posted for surgeries having cardiovascular problems, which inhalational agent would be preferred? One thing very clear, halothane should be completely avoided in any cardiovascular problem and in cardiovascular surgeries. Okay? ISO can be used. We are discussing halo, iso, CO, DES. Halothanes should be avoided. Should not be used for cardiovascular surgery. Okay. ISO can be used, CO can be used, DES can be used. All three can be used for cardiovascular surgery. Guys, whatever is the effect of isoflurane on cardiovascular system, exactly similar is the effect of desflurane and sevoflurane also on cardiovascular system. All three have same effect, right? All three can be used. But the recent edition of the books says that since DES is very stable, right, and least cardiodepressant, right, DES would be the agent of choice for cardiovascular surgery if desflurane is mentioned in the option. ISO is good, DES is best. Got it? So agent of choice becomes DES. Right? I can use all three. The latest edition says DES is best. Still, ISO is used at most of the places because DES is not available at most of the places. Got my point? Okay. So this was the effect on cardiovascular system. The third system is respiratory system. Halo, ISO, SIVO, DES. And the third is respiratory system. Respiratory system. Okay. Now guys, if you have seen patients on, let's say, under general anesthesia, if you have seen patients under general anesthesia, you may have noticed that when a patient is under general anesthesia, there is a bag in the hand of anesthetist who is pressing the bag and giving a positive pressure ventilation, or there is a ventilator attached to the machine which is going up and down and giving a positive pressure ventilation, right? Under general anesthesia, why do we support or control the ventilation of the patient? The reason could be two. One, that I have paralyzed my patient. I have not paralyzed. What is the effect of inhalational and IV anesthetic agent on respiratory system? Now remember, whether it is a drug or it is a condition, if it is producing loss of consciousness, they all depress respiratory center. Whenever respiratory center will be depressed, respiratory rate would decrease, hypoxia, hypercapnia would happen. Normally, if hypoxia, hypercapnia happens, respiratory drive is generated. But this respiratory drive, hypoxic, hypercapnic drive I am talking about, is blunted by anesthetic agent. More hypoxia, more hypercapnia. So, even if patient is capable of spontaneous breathing, we have to support the ventilation from time to time. Got it? So, what was the first point? First point was they all do the same thing, guys, inhalational or IV. Respiratory center depressed. Respiratory center depressed. Hypoxic, hypercapnic drive blunted. Hypoxic, hypercapnic drive blunted. Third, these 2 points we have already discussed. These are the same 2 points which I will write even in IV anesthetic agent. Third effect is on bronchus. Guys, what do we want our agent to be? Bronchoconstrictor or bronchodilator? Definitely bronchodilator. Bronchoconstriction would cause obstruction. And thankfully, most of the agents are bronchodilator. All inhalational agents bronchodilator. They all are bronchodilator. And till now we studied halothane bad for liver, bad for CNS, bad for CVS. One good thing about this bad agent, this is best bronchodilator. Bronchial asthma, anesthetic agent of choice. Got my point? So guys, in halothane, please write best bronchodilator. Best bronchodilator. Halothane is best bronchodilator. It is a wonderful bronchodilator. Best bronchodilator and in bronchial asthma, agent of choice. Got my point, everyone? Okay. If halothane is not mentioned in asthmatic patient and they are asking inhalational anesthetic agent of choice, then the second agent which is, let's say, equivalent to halothane in bronchodilation is sevoflurane. Sevo is also a wonderful bronchodilator. But today also, the best bronchodilator considered is halothane. Halothane not an option, then only Sevo would be the answer. Right? So Sevo is second best bronchodilator. All are bronchodilator, but I am just rating them. Sevo is second best bronchodilator. Bronchodilator. Okay? So Sevo is second best bronchodilator. If halothane is not in the option, then for bronchial asthma, the second agent would be sevoflurane. Got it? Okay. This was the third effect. Fourth effect on respiratory system. Guys, I hope you know what is hypoxic pulmonary vasoconstriction. Hypoxic pulmonary vasoconstriction. What do I mean by this? Hypoxic pulmonary vasoconstriction. I mean by this is that whenever there is hypoxia in any organ, the surrounding blood vessels dilate. There is a vasodilatation. But opposite happens in lung. In lung, alveoli which is hypoxic, the surrounding pulmonary capillaries undergo vasoconstriction to minimize ventilation perfusion mismatch. Right? To minimize ventilation perfusion mismatch, this is a good reflex operating in our lung, every normal lung. Guys, our alveoli does not, our whole lung, each alveoli does not get a uniform ventilation. Alveoli which are better ventilated, better perfused. Poorly ventilated, that is hypoxic, vasoconstriction, poorly perfused. Okay, so it's a good reflex, and this good reflex is blunted, is stopped to operate by inhalational agent, maintained by IV. So this good reflex, hypoxic pulmonary vasoconstriction, blunted by inhalational, right? Blunted by inhalational. Guys, it is maintained by IV. I will write an IV, it is maintained by IV, right? So for thoracic surgery, where there is already a ventilation perfusion mismatch, we avoid using inhalational and we try to use IV. Second benefit of TIVA. First benefit on neurosurgery, second benefit on thoracic surgery. Got it? So these are the 4 points which I need to discuss in respiratory system. All anesthetic agents are respiratory depressant. All blunt the respiratory drive. Most of them are bronchodilator, and inhalational blunts hypoxic pulmonary vasoconstriction and IV maintains hypoxic pulmonary vasoconstriction. Got it? So this was the effect on respiratory system. The fourth system which I will discuss is liver, hepatic. So halo, iso, sevo, des, and liver. Okay guys, which agent I told is bad for liver? Halothane. Why? It causes autoimmune hepatitis. Autoimmune hepatitis. Okay? It causes autoimmune hepatitis. Got it? Now guys, I told you it causes autoimmune hepatitis. So it is bad for liver, halothane. But apart from this, it causes one more major problem which makes it more bad for liver. What is that? We all know that liver has a dual blood supply. Total hepatic blood flow is equal to portal blood flow plus hepatic artery blood flow. Okay? Any reason if hepatic artery blood flow reduces, as in hypovolemic shock, there is a preferential perfusion to the vital organs. So liver etc. get less blood supply. So hepatic artery blood flow reduces. The portal blood flow would increase in the same proportion, but total hepatic blood flow would be maintained. Got it? Total hepatic blood flow would be maintained and there would be no hypoxic injury to the liver. This is called auto-regulation of blood flow in the liver, right? Auto-regulation of blood flow. Liver has an auto-regulatory blood flow system by which it maintains its total hepatic blood flow. This is the auto-regulation of blood flow is affected by inhalation, all inhalation agent little bit. Halothane completely disrupts it. IV anesthetic agent does not affect it at all. Third benefit of TIVA, right? But let us come on inhalational again. Halothane completely disrupts it. So halothane disrupts dual blood supply of liver. Disrupts dual blood supply. This auto-regulation of liver. So halothane should be avoided in any patient with pre-existing liver dysfunction. Should be avoided for hepatic surgeries. Right? Halothane should be avoided for hepatic surgeries. Right? Contraindicated for hepatic surgery. ISO can be used, SEVO can be used, DES can be used. All three can be used for hepatic surgery. All three can be used for hepatic surgery, right? Agent of choice, desflurane. What additional benefit DES has on liver? Not metabolized. No pressure on the liver. DES is a beautiful agent to be used for liver transplant surgery or liver problem patients, right? Among inhalational, desflurane undisputedly is best for liver. Got my point? ISO can also be used. Guys, where they don't have DES, they're happy with isoflurane. Got it? So for hepatic surgery, agent of choice, DES. Agent of choice among inhalational, DES. Right? Among inhalational, agent of choice for liver surgeries, desflurane. Right? So this is the effect on liver. Coming on kidney. Halo, iso, sevo, des. Next is renal, kidney. Guys, halothane, no bad effect on kidney, no bad effect. Iso, no bad effect on kidney. Sevo, we have discussed that it produces a byproduct which reacts with the CO2 absorber of closed circuit and produce another byproduct that's called compound A. This compound A is supposed to be nephrotoxic, theoretically. So theoretically, SIBO is nephrotoxic. There's no bad effect. Nothing to be discussed. Okay, guys, one more organ. I just want to tell you a passing statement, not in detail. Uterus. What is the effect of inhalation agent on uterus? We discussed on bronchus, halothane is best bronchodilator. Actually, halothane is best smooth muscle relaxant. And uterus is also lined by smooth muscle. So halothane is best uterine relaxant. So in cesarean section, if I use halothane, there is a high predisposition for uterine atony and postpartum hemorrhage, because halothane would relax uterus and uterus cannot contract and patient can go into postpartum hemorrhage because of uterine atony. So halothane we avoid for C-section surgeries also. Got it? So guys, halothane is best uterine relaxant. Just focus on halothane's effect on uterus. Leave the other organs, other inhalational agent. Got it? So halothane is best uterine relaxant. It's best uterine relaxant. Got it? Keep it in mind. Okay. So this is the effect of inhalation agent on different organ system. Before finishing off the pharmacodynamic properties, let me just tabulate what is the effect of these inhalation agent on different component of general anesthesia. What was the 5 component of general anesthesia? Let us revise. Number 1, loss of consciousness, right? Then loss of reflex response, right? Then amnesia, then muscle relaxation, and then analgesia, right? Muscle relaxation and then analgesia. Guys, halo, iso, sevo, des. Halo, iso, sevo, des. Okay. First 3 I told you when I was discussing general anesthesia introduction, all provides, right? Muscle relaxation, I am telling you, all potent inhalational agents provides. Analgesia, I am telling you, none of them provide. So none of our potent inhalational agent provides any analgesia. Keep it in mind. Got it? So none of the potent agent provides any analgesia. Got it? So this is all about the effect on component of general anesthesia. This finishes our 4 potent inhalational agents in current clinical practice. Their pharmacokinetic and their pharmacodynamic property. Okay, we left 2 agents we didn't discuss. They are not in clinical practice. Why? Because of some toxicity associated with them. What was those 2 agents? Methoxyflurane and enflurane. So let us discuss those 2 agents which are new agent but not in clinical practice. Methoxyflurane and enflurane. Guys, methoxyflurane. Now, let us go in sequence with all the points that we have already discussed. Just tabulating it here to, let's say, facilitate your learning. Not in use, most potent, most fluoride release, most nephrotoxic, right? And till these points we have already discussed, I would just add one more point. Type of nephrotoxicity produced by methoxyflurane. Methoxyflurane produces a unique type of nephrotoxicity. It produces high output, diuretic resistant, vasopressin resistant renal failure. Got it? Single liner question asked on methoxy. Type of nephrotoxicity produced by it. Actually, it doesn't produce a renal failure of oliguric or anuric type. It produces a polyuric type of renal failure, in which there is no sense of giving a diuretic, right? So it produces high output, that is polyuric type, high output, diuretic resistant, vasopressin resistant renal failure, right? High output, diuretic resistant, vasopressin resistant renal failure. And enflurane, not in use, of course, not in use. Then isomer of isoflurane, E for enflurane, E for epilepsy. Guys, I don't want to add any other point. 3 points we have already discussed. They don't ask any question apart from these 3 points. Got it? So this is all about our newer potent agent in clinical practice, not in clinical practice. Okay. Now I will discuss in very brief the older potent agent. Not in detail, not much asked in exam. Just few things I want to tell you about ether. But before I tell you anything about ether, right? The older potent inhalational agent, I want to discuss here a very important complication of general anesthesia related to this topic, malignant hyperthermia. A very important topic asked in exams. What is this malignant hyperthermia? Malignant hyperthermia, or we call it malignant hyperpyrexia. That is, or we call it malignant hyperpyrexia. What is this malignant hyperthermia or malignant hyperpyrexia? Guys, this is a hypermetabolic state. How does body goes into this hypermetabolic state? We have to understand. To just listen for a few seconds. Once you have understood, I'll write all the points, right? See guys, this is a pharmacogenetic disease. मतलब a condition which is expressed due to interaction of a particular gene with some drugs. Let us assume I have that gene. I have the malignant hyperthermia causing gene in autosomal dominant form, in its expressive form. But I am living a life as normal as any other person. I have no problem. But if I am exposed to certain drugs, this gene becomes activated and activates sarcoplasmic reticulum, which causes massive outpouring of calcium inside the cell. It causes massive outpouring of calcium intracellularly. And what happens? Intracellular calcium increases and this activates cyclic GMP pathway, makes the metabolism of the body 3 times, 4 times the normal. What will happen? If the body would go into this hypermetabolic state, CO2 production in the body would increase, right? Exothermic reaction, the temperature of the body would increase, blood pressure would increase, heart rate would increase, arrhythmia can happen. And because of this storm of metabolism, the cell breakdown or muscle breakdown start. So what will happen? Acidosis, hyperkalemia, myoglobinuria, rhabdomyolysis, renal failure. Got it? So this is what is malignant hyperthermia. Now let us write all the points one by one and let me tell you a few questions related to it. Okay? So malignant hyperthermia. First point. It is a pharmacogenetic disease. Pharmacogenetic disease. Okay? It's a pharmacogenetic disease. Second point. Gene is expressed in autosomal dominant form. Autosomal dominant form. Right? Gene is expressed in autosomal dominant form. Okay, third. Guys, drugs triggering this gene. This gene present even in autosomal dominant form would not be active until and unless we have exposure of these drugs. So what are the drugs which trigger malignant hyperthermia? Drugs triggering malignant hyperthermia. Triggering malignant hyperthermia. I'm writing MH for malignant hyperthermia from now onwards. Okay. Number 1, succinylcholine, a depolarizing neuromuscular blocker, which I will discuss in neuromuscular blocker. most potent trigger of malignant hypothermia. Second guys, all potent inhalational agent, halothane, isoflurane, sevoflurane, desflurane, methoxyflurane, enflurane, C-ether, chloroform, trilene, cyclopropane, all. Not the carrier gas, not nitrous oxide, not xenon. In books, you will find written halogenated inhalational agent, right? All potent inhalational agents are halogenated. Got my point? So, halogenated inhalational agent. Halogenated inhalational agent. Okay? Third, lignocaine. Lignocaine. Guys, lignocaine. Lignocaine is again a local anesthetic. Human cases yet not reported of lignocaine triggering malignant hypothermia. Animal studies have shown. Keep in mind for a direct question that which local anesthetic can trigger malignant hypothermia. Okay? Okay guys, I have malignant hypothermic gene. You gave me succinylcholine. It got triggered. What is the clinical features of malignant hypothermia? Fourth point, clinical features of malignant hypothermia. Clinical features. So, clinical features of malignant hypothermia. Clinical features are divided into two. Clinical features due to hypermetabolism, and clinical features due to cell lysis, right? Clinical features due to hypermetabolism, clinical features due to cell lysis. Okay, I told you metabolism becomes 3 times, 4 times the normal, and because of this hypermetabolism, the cell breakdown starts. ठीक है ना? So because of hypermetabolism, hypercapnia, hyperthermia, hypertension, tachycardia, arrhythmia. ठीक है? Hypercapnia, hyperthermia, hypertension, tachycardia, arrhythmia, right? And because of cell lysis, acidosis, hyperkalemia, cell breakdown, intracellular potassium would become serum potassium, hyperkalemia, myoglobinuria, then rhabdomyolysis, and ultimately renal failure, right? Ultimately renal failure. Got it? Okay, I have given all the clinical features. Tell me, according to you, what would be the most commonest cause of death in malignant hypothermia? Of course, arrhythmia. And if patient survives arrhythmia, renal failure. Correct? This is a condition with a high mortality. But we Indians need not fear because this is a very rare gene in our population. It is a common gene in Afro-American population. Got it? Okay, now it got triggered. How would you manage it? How would we manage it? Guys, anytime we suspect malignant hypothermia of getting triggered, we look for the precipitating cause. If I see any precipitating cause, any drug which I am giving which can precipitate it, I simply stop it. So first is stop the triggering agent if I see it. Number of times I don't get an evident triggering agent because this is not necessarily an intraoperative complication. This is a perioperative complication. You need an exposure of those drugs. You need not need a constant exposure of those drugs. So it can get precipitated post-op also. Correct? So if I see a triggering agent, I'll stop it. So coming on the 5th points, management. Number 1, stop the triggering agent. Stop the triggering agent. Okay? If I see it, then second, IV dantrolene infusion. IV dantrolene infusion. Guys, I am giving a patient dantrolene. Dantrolene stops the release of calcium from the sarcoplasmic reticulum. Malignant hypothermia stops. And third, symptomatic management. We have to do a very fast symptomatic management. Otherwise, we lose the patient before dantrolene has its effect. This is the sequence of management and this is the priority of management as well. Got it? So I have malignant hypothermic gene. And you have to give me anesthesia for some surgery requiring general anesthesia. You can't give me inhalational, they all trigger it. So what would you give me? IV. TIVA, safe on malignant hypothermia. Another benefit of TIVA. Got my point? So, 6th point. Intravenous anesthesia, IV, intravenous anesthetic agents, safe in malignant hypothermia. Safe in malignant hypothermia. And the best which we use is propofol. Propofol, anesthetic agent of choice. Anesthetic agent of choice. Now one thing, a very simple mistake which the students do, they ask drug of choice for managing malignant hypothermia. Answer is dantrolene. Anesthetic agent to be used in malignant hypothermia patient with malignant hypothermic gene. If this is mentioned, then answer is propofol. Propofol is not a drug to treat malignant hypothermia. It is agent of choice for anesthesia in patient with history of malignant hypothermia or in patient with this gene already diagnosed. Got my point? This is all about our malignant hypothermia. Very important from exam point of view. What are the questions asked? Drug triggering malignant hypothermia, drug safe in malignant hypothermia, clinical features of malignant hypothermia, right? Then they ask management of malignant hypothermia. All the points we have already discussed. One more point I want to specifically say. Guys, we wrote the clinical features of malignant hypothermia, in which I wrote that malignant hypothermia causes hyperkalemia, right? It causes hyperkalemia. This is the most common electrolyte abnormality seen in malignant hypothermia. Hypercalcemia never happens in malignant hypothermia. Intracellular calcium increases, not serum calcium. Got it? Hyperkalemia is one of the commonest electrolyte abnormality. Okay, this was asked in AIIMS actually. Most common electrolyte abnormality seen in malignant hypothermia. Got it? So this is all about malignant hypothermia and all about our potent agents we have already finished. So guys, newer potent agent we have finished. Let us discuss few things about older potent agent. Older potent inhalational anesthetic agents. Guys, before I tell you anything about the older potent agent, I want to ask from you people. Tell me, which day we celebrate World Anesthesia Day? Well, we celebrate 16th October as World Anesthesia Day. Why? Why we celebrate 16th October as World Anesthesia Day? Because first time ether was used on this day and first time a routine practice of anesthesia was started with ether anesthesia. So guys, ether was used first time on 16th October 1846. First time ether was used. And today, it's at present it is 2018. Do we still use ether? Actually, no, not in the major centers, not in the main centers, not in the advanced centers. We still use ethers in peripheries. We still use ether in the places where operation theaters, etc., and the facilities are not available, like warfare areas, etc., etc. Why is ether still used there? And why we don't use ether at good centers? What's the advantage? What's the disadvantage of ether? Just few things we have to know about ether. Okay, guys, I will tell you advantage and disadvantage. Focus on the first point which I am telling you. Maximum questions asked on ether is related to this first point which I will tell you, right? So advantage and disadvantage. Advantage and disadvantage of ether. Advantage of ether, guys. First advantage of ether, the main point of ether. Oldest agent of anesthesia ether, completely cardiovascular stable. ठीक है? Cardiovascular stable. The latest agent of anesthesia, inhalational agent, desflurane. Is it cardiovascular stable? No. It decreases blood pressure, increases heart rate. With ether, I don't even need a cardiovascular monitoring since it is cardiovascular stable. Blood pressure, heart rate, rhythm, cardiac output not affected. Wonderful. Era when it was used, we didn't even have the cardiovascular monitors. Got it? Okay, so it's cardiovascular stable. Second point, guys, it minimally affects the hypoxic and respiratory drive, the hypoxic and hypercapnic drive. Other anesthetic agents blunt these drives, hypoxic and hypercapnic drive. Ether also makes the patient unconscious. The respiratory center gets depressed. but to some extent the respiratory drives are preserved. So hypoxic and hypercapnic drive less affected, minimally affected. So patient unconscious but maintains his respiratory rate. Third benefit, oldest agent of anesthesia and only agent of anesthesia which can be labeled as a complete anesthetic agent providing all the 5 components: loss of consciousness, loss of reflex response, amnesia, muscle relaxation and analgesia. All 5 components provided by ether. So guys, with ether we need not supplement. So guys, when there was no concept of balanced anesthesia, we had ether. So good analgesic, good muscle relaxant. Good analgesia plus good muscle relaxation. Okay. Fourth, good bronchodilator. Good bronchodilator. It's a wonderful bronchodilator. Fifth, cheap. Very cheap. It's very cheap, right? So all are these good benefits. So why don't we use it? The major problem of ether, its speed, very slow induction and very slow recovery. So patient's discomfort when the patient was being induced, becoming unconscious, and when patient was recovering was very, very high with ether. So patient never liked ether, right everyone? We have to increase the patient's comfort, right? That's why we are giving anesthesia. So ether was not good in that. Slow induction, slow recovery. Slow induction, slow recovery. Okay? Slow induction, slow recovery. Okay. Next point of ether. Disadvantage. Guys, very bad smell. Slow speed and bad smell. How much discomfort it must be causing to the patient. So, irritant can cause laryngospasm. Bad smell, irritant can cause laryngospasm. Okay? Another problem of ether, when the fumes of ether was inhaled, it went from the respiratory tract, passed through trachea and bronchus, and hyperstimulated the tracheobronchial mucus and serous gland. What happened? In unconscious patient, the secretions were, let's say, outpoured in the oral cavity. Patient can aspirate if I don't secure the airway. Got my point? So, hyperstimulation of tracheobronchial mucus and serous gland. Hyperstimulation of tracheobronchial mucus and serous gland. Okay? Then, guys, ether is highly inflammable. Newer potent agent, all those we discussed, non-inflammable. Ether, highly inflammable. With ether, cautery contraindicated. If we use cautery with ether, blast in operation theatre. Got my point? So, highly inflammable, highly combustible. Ether can cause fire. If you go on YouTube, you can see the fire and the burn injury caused by ether anesthesia in the patients. So, dangerous agent to be used. Got my point? So, guys, all these points, the disadvantage makes ether not a good agent for a routine, let's say, modern anesthesia practice. But the advantage of ether, safety of ether, completeness of ether makes it still to be used at some peripheral places. Correct? So this is all about ether. Correct? So this is all I wanted to discuss about the older potent agent. I don't want to touch any other old potent agent. Not required. Not asked in exam. Got it? Okay, guys. So we have finished our potent inhalational agent. Now I will discuss with you carrier gas. We are left with 2 agents in inhalational agent, right? The carrier gas, nitrous oxide and xenon. So we will discuss the carrier gas, right? The first carrier gas which I will discuss with you, nitrous oxide. From exam point of view, very important. Why it's very important? You know, guys, whether I am using inhalational anesthetic agent or IV anesthetic agent for maintenance, Normally, we are using nitrous oxide in all our patients. Why? Because every patient needs oxygen. And we don't want to give 100% oxygen. We talked about it. So we have to give, along with oxygen, some other gas. And we are preferably using nitrous oxide because it is contributing in anesthesia as well. So practically this agent I am giving to all my patients. There are 12 points which we need to know about nitrous oxide. 10 facts, 10 simple facts, and 2 phenomena associated with it. Second gas effect, diffusion hypoxia. Got it? So let us first discuss the facts and then the phenomena associated with it. Okay? So before the first point of nitrous oxide, see this picture. See this cylinder of nitrous oxide. This is cylinder of nitrous oxide. Well, this is cylinder of oxygen. See this cylinder. This portion, this is called body. And this is called shoulder. This is body and this is shoulder. Now, if oxygen, body and shoulder is painted of different color, but of nitrous oxide, it's same blue color. So, whole cylinder of nitrous oxide is blue color. Oxygen, black body, white shoulder. Air, some other color. So, different gases have different color cylinders. Got it? Why we have color coding for different gases stored in cylinder? For easy identification, of course, right? But if you see some cylinders being used in operation theatre from years, because of lack of proper maintenance and care, they all look brown-black type. So this color coding was not solving the purpose 100%. People were doing mistakes, right? We needed a foolproof mechanism to prevent this mistake, right? We needed a foolproof mechanism to prevent this mistake. So, to prevent this mistake, a very important thing was established, something called pin index system. Something called pin index system. Okay. So, let us first know about pin index system, then we will come on nitrous oxide. What is this pin index system? Okay. See this. This is, let's say, the back of your machine. This is back of your machine. Okay. Where cylinders are attached. Okay. This has been made a depressed conical portion. A depressed conical portion has been made in the machine, which had 1, 2, 3, 4, 5, 6, 7 pins attached to it. And every gas cylinder was given a unique pair of pin. Like for example, nitrous oxide was assigned 3rd and 5th pin. Oxygen was assigned 2nd and 5th pin. So where nitrous oxide had to be attached, only 3rd and 5th pin were kept active. Rest were dummy pin. Anything, if I pick up the wrong cylinder at a wrong place, it would not fit. Any chance of manual error was totally removed. This is called pin index system. A system which prevent incorrect attachment of cylinder to machine. Got it? Okay. So let us write the first point of nitrous oxide. We are discussing nitrous oxide and let us write the first point. Nitrous oxide is stored in a blue color cylinder. Blue color cylinder. Okay? It is stored in a blue color cylinder. Pin index is 3, 5 of nitrous oxide. Got it? Then third point. Third point, MAC. MAC of nitrous oxide is 104, which makes it least potent. This is least potent. Then blood gas solubility. Blood gas solubility of nitrous oxide is 0.45. This is the lowest blood gas solubility. Not lowest, sorry. One of the low blood gas solubility, which makes it a fast agent. Nitrous oxide is fast agent. Then fifth point. Nitrous oxide is good analgesic. Our potent agent, no analgesia. Nitrous oxide, good analgesic. It provides a good analgesia. Now see on the screen. We have utilized this analgesic property of nitrous oxide in another gas. In making of another gas. Something called Entonox. I want to discuss about Entonox. In one cylinder, what was done? In one cylinder, 50% nitrous oxide was mixed with 50% of oxygen. Okay? And a new gas was produced. That's called internox. Now, what is the use of this internox? Well, if you see this question, what is wrong about internox? We just now discussed internox. I told you 50% nitrous oxide, 50% oxygen. Now this question is, what is wrong about internox? It is used for labor analgesia. It's a mixture of nitric oxide and oxygen in ratio of 50:50. Pin index is 7 of the cylinder and cannot be used for anesthesia. Even if you don't know anything about internox, you only know it's 50% nitrous oxide and 50% oxygen, you can solve this question. Because here nitric oxide is mentioned, not nitrous oxide. This is Ames question, a typical way of asking Ames question. They manipulate the fact which you have to know about that question. You have to know about nitrous oxide, internox, that it is nitrous oxide plus oxygen. And they have just manipulated that fact. Even if you don't know any other point, you can solve this question. Now guys, what is internox? It is a mixture of 50% nitrous oxide and 50% oxygen. Never used for anesthesia. For anesthesia, we have a separate cylinder of oxygen and nitrous oxide, and as and when required, we use this, right? We use whatever the concentration is required, 70-30, 60-40, 100% oxygen, right? We use in the inspiratory mixture. We don't need internox, the pre-mixed 50-50 for your, let's say, anesthesia. It was purely made for analgesia. Internox was a pure analgesic agent. Got my point? It's purely made for analgesia. So, internox, 4 points we have to know about it. Internox, composition, which we have already written. Composition. Second, we have to know what is the color coding of the internox cylinder. This is internox cylinder. This internox cylinder has blue body. It has blue body and white shoulder, right? The body is blue body, white shoulder, a bit lighter shade of blue, right? So, blue body, white shoulder. Got it? Now, the pin index is 7. And what it is used for? Used for analgesia, not for anesthesia. It's used for analgesia, not for anesthesia. First time it was used in UK for labor analgesia. It's used for labor analgesia, it's used for dental analgesia, but it's an analgesic agent. So it's used for labor and dental analgesia. It's analgesic agent, it is not anesthetic agent. Got it? So this is all about internox, and we have utilized the analgesic property of nitrous oxide in internox. Okay? Now coming on the 6th point. Guys, nitrous oxide is a sympathomimetic agent. We have written that when we were discussing the effect of nitrous oxide on EEG. It is sympathomimetic. So it will increase the blood pressure and it will increase the heart rate. Makes it cardiovascular unstable. Makes it cardiovascular unstable. 7th, nitrous oxide is a supporter of combustion, not like ether. Ether is a combustible agent. It is supporter of combustion like oxygen. Got my point? So it's supporter of combustion. Normally, nitrous oxide is not contraindicated when we are using cautery. It wouldn't cause fire on its own. Cautery, no problem, we can use it. But surgeries in which there is huge incidence of airway fire, there we try to avoid nitrous oxide because it is supporter of combustion. It will increase the size of fire. We cannot avoid oxygen, but we can avoid nitrous oxide. So for laser surgeries, we try to avoid nitrous oxide. So supporter of combustion, so it's contraindicated for laser surgery. We don't use it for laser surgery. Here I want to discuss with you another complication of general anesthesia, airway fire. Few questions on All India AIIMS has been asked on airway fire. Just see on the screen. This is your machine. This is the circuit. This is the airway, the advanced airway, the ET tube, and this is the patient. Okay. For machine, you are giving your patient and nitrous oxide, oxygen, both supporter of combustion. and you are giving DES, not supporter of combustion, neither combustible gas. And the surgical site is near the airway, oral cavity surgery, throat surgery, lip surgery, laser surgery, in which tumor of the throat is being ablated by the laser, that is microlaryngeal surgery. Surgeon misfires, and this tube catches fire. Surgeon is the first person to see it. He will tell the anesthetist, airway has caught fire, manage it. What do? The first thing we do, we disconnect the circuit, because these two gases will further increase the size of fire. So circuit disconnection. Then in these type of surgeries, we are always ready and prepared with normal saline and distilled water filled syringes. We squirted on the fire and try to extinguish it. Then we remove the tube. This tube is damaged. This cannot be used for ventilation. I remove it. But I can't leave the airway unsupported. Why? Edema and obstruction can happen. So I re-intubate with a fresh ED tube. And then I give a shot of antibiotic to prevent any infection and shot of steroid to prevent airway edema. This is protocol management of airway fire. So management of airway fire. Airway fire. Number one, circuit disconnection. Disconnection of circuit. Number two, normal saline, distilled water filled syringes used to extinguish the fire. Used to extinguish the fire. We try to extinguish it. Number three, remove the endotracheal tube which has been damaged. Re-intubate with fresh tube. Re-intubate with fresh endotracheal tube, right? And fifth, IV antibiotic plus IV steroid. IV antibiotic plus IV steroid given. This is the management of airway fire, protocol management of airway fire. Got my point? Question has been asked in all India names. Keep it in mind. Okay. Next point. This was our point that nitrous oxide is supporter of combustion. Got it? Now coming on the eighth point. Very important eighth point. Nitrous oxide is 35 times more soluble than nitrogen. If in our body there is any air containing cavity and if we take nitrous oxide, it will replace nitrogen. And 1 part of nitrogen can be replaced by 35 parts of nitrous oxide. So the size of that cavity would increase. If it's mild pneumothorax, it can become severe pneumothorax, right? If it's a bit dilatation of the obstructed lumen of intestine, it will get grossly dilated. Because of this problem, there are some absolute contraindication to the use of nitrous oxide, correct? So nitrous oxide expands air containing cavity. It expands air containing cavity in body. Because of this, it's absolutely contraindicated. Absolute contraindication. And guys, I am putting a red line on it and trying to tell you that it is a very important point which is asked in question. Absolute contraindication of nitrous oxide. Number 1, pneumothorax or pneumopericardium. Pneumopericardium. Number 2, intestinal obstruction. Number 3, cochlear implant surgery. Number 4, vitreoretinal surgery. Surgery on vitreous and retina. And number 5, laser surgery. Surgeries in which laser is being used. Cochlear implant surgery, we are already making a cavity in the ear to place the implant. If I use nitrous oxide, size of cavity will increase. So these are the 5 absolute contraindication of nitrous oxide, important from exam point of view. Apart from these, there is no absolute contraindication. In guidebooks, they have written a lot of contraindications like middle ear, etc., surgery, etc., etc., which is not important, not an absolute contraindication. Got it? 9th point, nitrous oxide inhibits vitamin B12 dependent enzyme. So what will happen if vitamin B12 dependent enzyme will be inhibited? What will happen? Well, peripheral neuropathy and megaloblastic anemia. So peripheral neuropathy and megaloblastic anemia. So these are the 2 problems of nitrous oxide because it inhibits vitamin B12 dependent enzyme. And last point, bone marrow depression. It causes bone marrow depression. So these are the 10 points which we need to know about nitrous oxide, right? Apart from these 10 points, we need to know 2 phenomena associated with it: second gas effect, diffusion hypoxia. Both are asked in exam, both I'll explain. But if in exam there is a confusion created or anything comes in your mind, keep one thing in your mind clear. If the question is framed in such a way that they are describing the scenario of induction, the answer would always be second gas effect. It is seen during induction. And if the scenario is of reversal, the answer would always be diffusion hypoxia. Got my point? If you see this question during induction of general anesthesia, you see this during induction of general anesthesia, this line, the answer would always be second gas effect, right? If it was during reversal of general anesthesia, then it would have been the diffusion hypoxia or whatever. Okay? Induction means the answer would be second gas effect because this is seen during induction. Now what is this second gas effect? Just understand first, then we will write it. This is your machine. This is circuit, this is airway, this is alveoli, blood and CNS. Okay. I am giving my patient nitrous oxide, oxygen and never DES for induction. What do we use for induction among inhalational? SIVO. Inhalational induction agent of choice, SIVO. I am using SIVO, sevoflurane. I have turned on the vaporizer. 4% SIVO is going in the inspiratory mixture. Rest 96% of the inspiratory mixture, 70-30 nitrous oxide and oxygen. This is entering into the circuit, into the airway and reaching the alveoli. If I take out a sample of gas from airway, what should be the sevoflurane's concentration? What I am giving from outside, that is 4%. What should be the sevoflurane's concentration in airway if I take out a sample of gas? 4%. And if I take out a sample of gas from alveoli, what should be the concentration of sevoflurane in this? Definitely either 4% or less because it will be uptaken in the blood. But it is more than 4%, little more than 4%, 5%, 6%, but more than 4%. This is what is second gas effect. What is second gas effect? Effect of nitrous oxide on accompanying agent, that is sevoflurane, to increase the concentration of accompanying agent in alveoli. Nitrous oxide increases the concentration of uptake of accompanying agent in alveoli. This is called second gas effect. Got it? So what is second gas effect? Effect of nitrous oxide on second gas, that is accompanying gas, to increase the concentration of accompanying gas in alveoli. This is called second gas effect. Got my point? This is a good effect or bad effect? What say? Definitely it's a good effect because we have discussed CNS concentration is directly proportional to alveolar concentration. If alveolar concentration increases, we will attain the CNS concentration fast. Got my point? This makes the speed of induction fast. Got it? So this is a good point. This is a good effect. This makes speed of induction fast. This makes speed of induction fast. So it's a good effect of nitrous oxide which makes the speed of induction fast. So this is what is second gas effect. So this is all about second gas effect. Important from exam point of view. Now coming on diffusion hypoxia. More important from exam point of view. What's this diffusion hypoxia? Diffusion hypoxia. What is this diffusion hypoxia? One point I have already told you. It is seen during reversal, not during induction. Now let us make a scene of maintenance of anesthesia. This is your machine. From machine, the tubings come out. And this is attached to the airway, alveoli, blood and CNS. So for maintenance of GA, I am giving N2O, nitrous oxide plus oxygen and DES. It is going into the circuit, into the airway, reaching the alveoli, uptaken in the blood and going to CNS. As I told you, I continuously go on giving this. So the concentration gradient is towards CNS and patient remains unconscious. Surgery finished. I have to wake up my patient. To wake up my patient, I have to stop all anesthetic agent. I stop DES, I stop nitrous oxide both. Let us talk only about nitrous oxide for the time being. When I stop nitrous oxide, its supply into the alveoli stopped. And the pressure gradient which was from alveoli to blood reversed, became from blood to alveoli. And nitrous oxide, we have discussed blood gas solubility. What we had written? 0.45. So with a reverse concentration gradient, this comes out of the blood into the alveoli very fast. It has a low blood gas solubility. And whatever oxygen is in alveoli, let's say I have 40% oxygen in the alveoli, nitrous oxide dilutes it. More nitrous oxide. The yellow one is for oxygen and the red one is for nitrous oxide. So nitrous oxide from blood comes and dilutes the oxygen and makes a hypoxic mixture. This is what is diffusion hypoxia. Hypoxia due to rapid diffusion of nitrous oxide from blood to alveoli during reversal of general anesthesia. Got it? So this is what is diffusion hypoxia. Write it. What is diffusion hypoxia? Hypoxia due to rapid diffusion of nitrous oxide from blood to alveoli during reversal of general anesthesia. Got it? This is what is diffusion hypoxia. So guys, as I started nitrous oxide, I told you, practically we are giving it to all our patients. So there is risk of diffusion hypoxia to all our patients. How do I prevent it? See, if there is 40% oxygen in alveoli, it can get diluted and become a hypoxic mixture. But if I give 100% oxygen from outside and make the alveolar oxygen concentration 100%, same thing will happen. Same thing will happen. It will get diluted, but it will not get diluted enough to become a hypoxic mixture. So treatment and prevention of diffusion hypoxia is same. 100% oxygen. Treatment and prevention of diffusion hypoxia is same. 100% oxygen. Got it? Okay. Now this diffusion hypoxia is also called Fink effect because this was discovered by Dr. Albert Fink. Who described it? Dr. Albert Fink. And it is also called third gas effect. A new nomenclature, third gas effect. Okay? This problem of diffusion hypoxia is a very short problem after stoppage of nitrous oxide. Only post discontinuation of nitrous oxide, the risk of diffusion hypoxia is only for 4 to 5 minutes, not beyond 5 minutes. So that's why it is not such a big risk for us during anesthesia. Got it? So risk of diffusion hypoxia is only for 4 to 5 minutes post discontinuation of nitrous oxide. Got it? So this is the only time where we have to be careful about diffusion hypoxia. 4 to 5 minutes post discontinuation. This is all about diffusion hypoxia and all about nitrous oxide. So we have finished nitrous oxide and we are left with only one inhalational agent. But before I discuss that, just let me revise nitrous oxide for you very fast. You need not copy anything, just listen. Nitrous oxide. Okay. What are the points we have discussed? MAC 104. Blood gas solubility 0.45. Good analgesic. Okay. Then supporter of combustion. Then cardiovascular unstable. Then it causes peripheral neuropathy. Then it causes megaloblastic anemia, bone marrow depression. It causes diffusion hypoxia. Guys, I have separated few good point of nitrous oxide and few bad point of nitrous oxide with an intention to tell you the last agent which I want to discuss with you is xenon, a latest inhalational anesthetic agent. It has improved all the good properties of nitrous oxide and has removed all the bad properties of nitrous oxide. Xenon, all the properties of xenon can be remembered easily. All the questions of xenon can be solved easily just by focusing on its 2 points which you already know. Inert gas, ideal gas. We are blessed. We have a gas which is inert but has anesthetic potential. We are blessed that we have an ideal inhalational anesthetic agent fulfilling all the qualities of an ideal inhalational anesthetic agent. Let us discuss few points of xenon. Right? What is xenon? Xenon is an inert gas. It's a inert gas. Okay, it's an inert gas. Okay. MAC of xenon is 70. So this makes it more potent than nitrous oxide. Definitely less potent than potent inhalational agent, but more potent than nitrous oxide. Right? Less MAC, high potency we have discussed. Blood gas solubility of xenon, guys. This is the most important point. I am making it red. Right? Blood gas solubility of xenon is 0.19. Lowest blood gas solubility, making it the fastest inhalational anesthetic agent. Till now, whatever inhalational agent is in clinical use, xenon is fastest. Fast induction, fast recovery. Okay, better analgesic than nitrous oxide. Okay, it's inert gas. So not supporter of combustion. Not supporter of combustion. It's inert gas. Cardiovascular stable. It's inert gas. So it is metabolically inert, wouldn't affect any enzyme, wouldn't even get metabolized. So metabolically inert, doesn't get metabolized, neither affects any enzyme. Guys, it is environmental friendly. Environmental friendly. Now very important, environmental friendly. Nitrous oxide is not environmental friendly. It is producing contributing in the global warming, and tons of nitrous oxide is released everywhere. So xenon is so good. So we should use it. We don't use it. Why? Very, very costly. It's an inert gas, cannot be made by a chemical reaction. So it has to be produced, it has to be separated from atmospheric air present in trace amount. So cost of separating it from atmospheric air is very, very high. That's why it's not used clinically. At present, they are doing a lot of research on xenon so that they make a cost-effective way of making a xenon, producing a xenon in a cylinder. Got it? So the problem is very costly. That's why it is not in clinical use. Not in clinical use, that does not mean it cannot be the answer. If they ask making up a clinical scenario, common agent in use or in use, definitely xenon cannot be answer. But if they ask describe a clinical scenario and they ask most appropriate inhalational agent in this patient with xenon in the option, consider the pharmacokinetic and pharmacodynamic property of xenon and come with the answer. They are asking what is the appropriate in this patient, right? And they have to compare the pharmacokinetic and pharmacodynamic property of xenon with the other agents. Not in use they are asking. So xenon can be the answer. Got my point? So this is all about xenon. And this finishes the biggest topic, inhalational anesthetic agent. So this finishes our biggest topic, inhalational anesthetic agent. We have finished inhalational anesthetic agent, and the next topic which I would discuss with you is intravenous anesthetic agent. Got it? I have finished inhalational. Next topic would be IV anesthetic agent. Both acts on central nervous system. In inhalational also I haven't mentioned where on CNS. In IV also I will not mention where on CNS, because I want all of you to remember all inhalational, all IV acts on GABA receptor in brain. They all acts on GABA receptor in brain. All inhalational, all IV. Except two agents. In fact, three agents. Ketamine, xenon and nitrous oxide. These three acts on NMDA receptor and methyl D-aspartate receptor. Got it? Rest all on GABA. Rest all anesthetic agent on GABA receptor in brain. Okay? Fine.